So hello everyone. So my name is dry eye disease my topic is my dry eye disease in a patient with rheumatoid arthritis, which is unmasking secondary Sjogren's syndrome. So we had a 43-year-old female came to an IOPD with chief complaints of irritation, burning sensation, grittiness, foreign body sensation, DOV and mild pain in both eyes since 10 to 15 days. She was relatively asymptomatic 3 to 4 months back when then she developed all these symptoms which was followed by diminution of vision and mild pain in both eye, which was gradually in onset, progressive in nature and worsens by the end of the day and not relieved by any eye drops. Also, she had complaints of dry mouth for the past 2 to 3 months, which was again gradually in onset and progressive in nature, and she had a constant urge of drinking water. And also with a joint stiffness in early morning, which gradually improves as the day passes, and there was no any association of watering from both eyes, diplopia, difficulty in closing eyes or DOV at night. She was already a diagnosed case of rheumatoid arthritis since past 2 years and has been on the treatment for the methotrexate and hydroxychloroquine. History of contact lens wear was occasionally, and lubricating eye drops she uses occasionally. There was no any other history like eye surgery or any ocular trauma or installation of topical medications other than lubricating eye drops. There was no any chemical exposure or any radiation exposure and other systemic illness than rheumatoid arthritis, hypertension or diabetic mellitus. So on examination, she had a visual acuity in right eye, counting figure 5 meters, and in the left eye 618. With following there is a BCVA and near vision. Her NCT in right eye was 12 and in 15 in the left eye. So we had ocular examination done where in the right eye she had few filaments with EP defect of 2 by 1 mm with superficial vascularization and variable depth corneal opacity. And in the left eye there was few SPKs and else was normal. So we had some investigations done where the test for the tear film volume assessment, we had done Shermer test, another is T-Bud test and corneal vital stents. We also done impression cytology, which showed amount of goblet cells in the case of dry eye, which was significantly reduced. So following the Shermer test, in our patient there was 4 mm in right eye and values for the left eye was 12 mm, which was severe in right and mild in the left. So we also done the T-Bud test, which showed in the right eye there was 4 seconds and in the left eye there was 5 seconds. And also the fluorescein clearance test, which normally the dye cannot be detected at 20 minutes, but in our cases there is a delayed clearance. And for the corneal vital stents, we had done fluorescent dye 2% strip, which showed these findings. For the right eye there were multiple filaments, and in the left eye the lusterless cornea. Blood investigation showed raised ESR and CRP along with the positive RF factor, and minor salivary gland biopsy showed some lymphocytic infiltration. This is the revised American European criteria for diagnosis and classification of dry eye disease, which is the ocular symptoms, oral symptoms, ocular signs and histopathology along with the oral signs and autoantibodies. So following all the criteria which usually we do for the diagnosis of secondary Sjogren's syndrome in the patient with the defined connective tissue disease or presence of any one symptom or plus 2 of all the signs objective categories must be met. So we had some differential diagnosis in our case, but like conjunctivitis or lead abnormalities, severe MGDs. So there were the treatment options as per the DUEs, level 1 to 4, and these are the 4 levels which has been recommended for the treatment, but we usually give a blanket therapy for the dry eye disease. So I will directly jump to what we can do in our patient. So we started for the right eye and acetylcysteine 4% eye drops QDS, Moxi QDS and fluorometholone cyclosporine, and 2:1 alternate hourly CMC 0.5% and SOHA 0.1% eye drops. We kept our patient on routine follow-up of 2 weeks. It was observed that there was symptomatic relief in the left eye as compared to the right eye. EP defect was healed out, and then we tried a temporary punctal plug in the right eye as well, following which there was a reduction in the filaments in the further follow-ups. So is our patient need long-term treatment? Any multiple treatment regimen can lead to poor compliance because as we started so many drops. So what measures can we take in such chronic cases?
So these N-style drops are commercially available?
No sir, we usually make it with a dilution along with the CMC 4%, not commercially
And
available.
how long you can keep it?
On the treatment.
Once it has been prepared, so how long you can keep it?
Sir, 2 to 3 days we usually give, we follow up the patient after 3 days and we again freshly give.
So for every 2-3 days the patient has to come back again?
So yeah, but because it is not commercially available,
Yeah,
and
I understand.
we
So
have
how
to
do
make
you
it very
ensure the
fresh.
compliance?
Yes, sir.
That can be, I think, the problem.
Yes, sir.
Big problem.
That's why there is a.
So preservative. And how you had said the temporary punctal plug.
Yes, sir.
How long? Temporary means how much?
For the
is it?
say 6 months, 3 to 6 months, we can do the temporary for silicone or the hyaluronic acid punctal plugs.
And you have followed this patient up to what time?
Sir, for the 1 year. 1 year. Yes, sir.
Okay, time is up, no issue. Go ahead. Any questions? Pushkar, did you be ready for that?
One year.
Thank you.
A very good evening to everyone. I am Dr. Pushkar and I will be presenting on vitamin E deficiency induced xerosis and corneal epithelial defect in post-ROP laser. I am a vitreoretinal surgeon, so I had experienced this thing in a certain abnormal way. So vitamin E is essential for vision, epithelial growth and immune function. But if it's deficient, it leads to xerophthalmia, keratomalacia and blindness. So preterm infants are especially vulnerable because of the limited hepatic stores at birth of vitamin A, impaired absorption, and inadequate supplementation via parenteral or enteral nutrition. Risk is higher in presence of ROP, poor nutrition, and recurrent infections. Having said that, my case highlights preterm infant with regressed ROP developed xerophthalmia and corneal ulcer due to vitamin A deficiency, and the baby showed significant improvement with vitamin A supplementation, and the case underlines importance of nutritional assessment in preterms with ocular surface diseases. So my case is of 2-month-old female infant with a period of gestation 30 weeks and age at presentation was 46 weeks. The birth weight was 850 grams, current weight was 2 kg, and there was history of ROP zone 2, stage 3, and laser was done. And there was history of 2 units of blood transfusion, CPAP, feeding with express milk without fortification. And the baby presented with frequent crying episodes and was observed repeatedly touching her eyes. So on examination, it revealed that there was a conjunctival xerosis in both the eyes and a corneal ulcer in the right eye. Confirmed in the right eye with the help of fluorescent stain. The ulcer was central sparing visual axis, approximately 2 mm in diameter, superficial, associated with reduced corneal sensations, and smears were negative for bacteria, indicating a sterile melt. So these pictures show a small epithelial defect in the right eye, while conjunctival xerosis is clearly seen on the left eye of the baby. The investigations, we went ahead, since it was a small baby with a corneal ulcer, what it could be, so we went ahead and got a vitamin A tested for the baby, and it came out to be 108.27, while the normal values in 1 to 6 years is 200 to 400. Coming to the management part, the infant was immediately started on 1 lakh international units of vitamin A orally, along with topical antibiotics, steroids and lubricants. There was significant improvement in conjunctival health, and the corneal ulcer showed signs of healing. Post-treatment vitamin A levels were not assessed. So my takeaway points are: maternal vitamin A status, which we hardly see during the pregnancy, significantly influences the newborn's vitamin A reserves, as most transfer occur in the 3rd trimester, which these preterm ROP babies miss. The deficiency per se can lead to xerophthalmia, a spectrum of ocular condition ranging from night blindness to corneal ulceration. corneal ulcer in vitamin A deficiency is usually bilateral, but in my case, there was cirrhosis in one eye and ulcer in other. Less than 32 weeks babies have very low vitamin A stores versus the term infants who almost have a 6 months reserves in them. So less than 32 weeks preterm and less than 6 months with vitamin A deficiency. In less than 1.5 kg, we give 3000 international unit per kg per day as quoted by Tinali et al. In the study. While infants less than 6 months with xerophthalmia, we need to give 50,000 international units. While in my case, we had given approximately 1 lakh international units per day because there was already an ulcer. So risk factors are reliance on unfortified breast milk, prolonged NICU stay, and transfusion. Role of vitamin is important in retinal development and rhodopsin. Xerophthalmia and corneal ulcer shows deficiency despite normal serum levels. High dose vitamin A is safe in acute deficiency. While the recommended dose is 50,000 international units, for continuous 3 days we give 1 lakh international units. Early vitamin A monitoring in NICU, which is again not done, have prevented severe ocular complications. So conclusion, routine screening with vitamin A in NICU, particularly those with ROP, may be warranted, especially if the baby is coming to you with a watery eye or maybe an ulcer in the eye, then you need to do it. And clinicians should adhere to established guidelines of vitamin A supplementation while remaining alert to deficiency in high-risk infants. With that, thank you so much.
Thank you, gentlemen. My simple one question to you.
Yes, sir.
You have given treatment, you will be giving treatment. What is your first advice to the mother of the baby? Any advice you want to give her?
Post-treatment or when I have diagnosed?
No, you have seen the patient, now you have started treatment for vitamin A deficiency.
Correct.
What advice you want to give that postpartum lady?
Continue with a good breastfeed.
Yes, that's the basic point. Breastfeeding is very important in that case.
Yes.
And good food habit of her also.
Sorry, sir?
For her nourishment also, you have to take
Yeah. For her reserves
Any
also we
question?
have to tell her.
So, Dr. Dheer, is it a routine practice to get the vitamin A level in all ROP patients?
So that's what I bring to the point to you, and this article is on going to be get published in IGO. So this is not a routine practice which is being done in NICU, but since we have experienced such kind of cases, now this was the one which I have case reported, probably published in next journal, which IGO, which is coming. So I'm telling my ICU people to get vitamin A also done. Since they are already taking the blood samples, why not to just go for a vitamin A? And these are like 10 to 20% of the babies who are preterm with them. So there is no harm in getting this thing done also.
Next, be ready, Deepak.
Thank you.
So, whenever you see a ROP patient,
Yes, sir.
whether you go for any test or not, but must advise to the mother.
Yeah. So mother care,
Yes,
the
that is
KNC.
much more important in that condition.
Yeah.
Okay.
Thank you so much.
No, still not. I have not seen.
It's per se not there, but Tinali et al. I have put a reference also. They have actually done studies in very low birth weight babies where
Sir,
they
Ajo,
have
sir, this is
prophylactically given vitamin A and seen that they
please.
don't have any ocular issues. Thank you.
Thank you, Dr. Dheer. So next talk is by Dr. Deep Shekhar Das. Case presentation by Dr. Deep Shekhar Das. It has been years that he has listened to someone.
Good evening, everyone. My topic of case presentation is blinded by the cure, that is lenalidomide's rare ocular wrath. Can I have my slide, please? So, a 50-year-old female presented with extensive rashes all over her body for the past 1 day, and she was a known case of multiple myeloma and has been receiving bortezomib, cyclophosphamide and dexamethasone regimen for the past 4 months. And 1 day prior to the onset of the rashes, she had received lenalidomide. On general examination, she had tachycardia with a pulse rate of 134 per minute. The remaining vitals were stable. There was extensive desquamation of skin all over her face and body. So this is the clinical picture of the patient at presentation. So you can actually appreciate that the whole of the face, the skin is completely desquamous. There's a lot of necrosis also all over the forehead. Coming to the lashes and the eyelids per se, you can appreciate that the lashes are completely matted. And the lower lid, you can appreciate there's ectropion. The lashes is completely matted. And also, if you look more in the next photographs I will show you. So on ocular examination, we noted that there was the visual acuity in the right eye was 636 and left eye it was 612. And there was again, the lids were completely having poor skin, and the skins were exfoliating coming out, and the lashes were matted. Coming to the photographs of the right eye and the left eye, here you can actually appreciate in the right eye there was an epithelial defect which was a kind of a spindle shape in nature, and it was roughly 12 into 4 millimeter in size. Unfortunately, we did not have fluorescent angiography or fluorescent dye per se, so that we could stain them. The patient was admitted in ICU. And this is the images of the left eye. We also appreciate that there were multiple developing symblephrons. So based on these findings, a diagnosis of Stevens-Johnson syndrome was made, and the patient was started on intravenous fluid, antihistaminics, both topical as well as oral, and antibacterial medications were started on oral were started, and the patients also underwent regular swipes using glass rods for breaking the developing symblephrons. And we also started topical as well as oral steroids, and there was immediate marked improvement in the following 5 days. The epithelial defect disappeared completely, and the skin actually healed up. This is just 5 days post treatment. So coming to the discussion, lenalidomide is an analog of thalidomide. However, compared to thalidomide, which is more commonly used, it is more potent, and it has more anti-angiogenic effect and has a better safety profile. Nowadays, it's kind of one of the first drug to go to for treatment of multiple myelomas. However, in the last few decades, only 3 cases have been reported of Stevens-Johnson syndrome. However, when you're talking about SJS, the degree of severe ocular SJS has never been reported. To conclude, lenalidomide, although rarely, but can cause severe form of ocular Stevens-Johnson syndrome. However, an early diagnosis with prompt management can yield satisfactory results. So this is the pre and post management images. These are the key points. That is, lenalidomide can induce SJS, and early detection is crucial. Supportive care is very essential. Ocular management has to be done properly, and multidisciplinary care is essential, where a collaboration has to be there between the dermatology, ophthalmology and oncology department. Thank you.
Thank you, Dr. Deep Shekhar.
नहीं हमारे लिए कुछ नहीं.
So is it this lenalidomide is a routine?
So it's currently one of the go-to drugs for multiple myelomas. Nowadays, it's.
And what is the basic role of this?
So it's a thalidomide. Like it was previously thalidomide, it's a better potent variant of thalidomide. So this actually acts. It's a chemotherapeutic agent. So it typically restricts the proliferation of the blast cells. If you want the exact DNA, which level I'm not able to recollect as of now, but we usually do it. It's regularly used otherwise.
ये angiogenesis को रोकता है.
It has a part of it is antigenetic. It has a part of it is anti-angiogenetic, but it's not purely just based on the angiogenetic factor it's used.
Okay, next speaker, please.
Dr. Vrinda Perisamy.
Good afternoon all, I am Dr. Brinda. I will be presenting on a case series of isolated white eye viral endothelitis in healthy young, silent yet sight-threatening. Viral endothelitis is characterized by a triad of corneal edema with keratic precipitates and mild iritis as shown in the image. It can have 4 forms where disciform is the most common and herpes simplex virus is the most common etiology, and viral endothelitis is a known cause of corneal endothelial dysfunction in immunocompromised middle-aged and older adults. But in our case series, I'll be discussing about the isolated white eye viral endothelitis, where there is an isolated corneal edema without anterior chamber inflammation. That is, the patient doesn't have any keratic precipitates, iritis, circumciliary congestion, high intraocular pressure, or there are no risk factors like systemic illness, immunosuppression, stress, or ocular trauma. The objective is to describe the clinical presentation, management, and outcomes of the isolated white eye viral endothelitis in young, otherwise healthy individuals. I'll be discussing about 5 atypical cases. All patients were treated on tablet acyclovir 400 mg 5 times a day for 2 weeks, followed by BD for 4 weeks, and topically they were on loteprednol eye drops QID with weekly taper, sodium chloride eye drops, topical antibiotics, and lubricants. Resolution of corneal edema both clinically and on ASOCT was considered as a positive clinical response. Coming to the first case, it's a 21-year-old healthy female who had blurry vision in the left eye for a week with central and paracentral corneal edema without any congestion. Vision was 612 with a reduced corneal sensation and normal IOP. On slit, there was corneal edema with thickened DM endothelial complex. The epithelium was intact and no KPs and AZ reaction. This was evident on ASOCT with the increased ECT of 858 microns. On 1 month follow-up, the corneal edema resolved with the minimal haze and the vision was 6/6. The ASOCT shows the resolution. The second case is a 25-year-old healthy female who had blurry vision in the right eye for 2 days. On clinically, she had mild central corneal edema with faint decimate folds and without any congestion. The vision was 6/9 with reduced corneal sensation and normal IOP. On slit, there were faint DM folds and there were no KPs and the epithelium was intact. On the ASOCT, there were posterior stromal edema with endothelial irregularity and increased ECT of 686 microns. On 1 month follow-up, the corneal edema resolved completely on clinically and on ASOCT with a vision of 6/6. Third case is a 17-year-old healthy female who had diminution in the left eye for 15 days with the central dish-shaped corneal edema without any congestion. Vision was 612 with reduced sensation and normal IOP. On slit, there were thickened DM endothelial complex without any KPs and high CCT on ASOCT with 784 microns. On 1 month follow-up, the corneal edema settled with residual stromal haze, which was seen on the ASOCT also with the vision of 6/9. Fourth case is a 29-year-old healthy female who had diminution in the vision in the left eye for a month with a mild central corneal edema. As the patient presented late, she had minimal scarring also. There were no congestion. Vision was 6/12 with a reduced corneal sensation and normal IOP. On slit, there were posterior stromal scarring, and on ASOCT, the scarring was noted. Still, we started on treatment and the patient had drastic response with the resolution of the scarring and the vision resolved to 6/9. Fifth case is a 14-year-old healthy female who had diminution of vision in the left eye for 5 days with a central dish-shaped edema without any congestion. Vision was 6/24 with a reduced corneal sensation and normal IOP. On slit, there were corneal stromal edema with endothelial irregularity as shown in the ASOCT also. On 2 weeks follow-up, partially the edema resolved with the minimal posterior stromal scarring and the vision was 6/9. Coming to the discussion, all patients in our case series were very young, between 14 to 29 years, and all were females, and they were healthy and immunocompetent. In the review of literature, there was a single case report of corneal endothelitis in a juvenile male. In our case series, all were females. And in our case, early presentation had complete resolution. When the patient present late more than a week, they had minimal residual haze, but the scarring was also reduced on treatment. So early diagnosis is prudent to prevent the endothelial cell loss. The postulated mechanism of this white eye viral endothelitis, whether it is a separate entity or it is a early phase of classic herpetic endothelitis, or is there any role of UV exposure, blue light or lifestyle modifications, or is there any hormonal imbalance as all patients were females, or is there any role of latency assisted transcript causing early reactivation in healthy young patients? Take clinic points should be when a young healthy patient presents with isolated corneal edema with reduced corneal sensation, even when the IOP is normal and no KPs and no iritis, without any congestion, think of viral endothelitis and start the combination therapy of oral acyclovir with topical steroids, which is effective both in early and late presentation. Thank you.
Sure.
Do you think oral acyclovir in these cases is really effective? And for how long?
Sir, tablet acyclovir 400 mg BD for 2 weeks, 5 times for 2 weeks, and BD for 4 weeks, 6 weeks of treatment as routine endothelitis treatment, sir. Hello, sir.
Why females?
So that's what we are postulating. But no one had any relation to menstrual cycle or not. We asked history for that, but each one were in different phases of the menstrual cycle. There were no correlation, but we have to further investigate about this case. Without any congestion and keratic precipitates, young healthy girls are getting the corneal edema with reduced sensation. Girls in 14 to 28 years. Is a hormonal change or whether the
क्या sir? And now they are mentally more intelligent, but physically still they are at the same place. Mentally they are stronger than us now, but physically they have some immunic problem. Okay, thank you, doctor.
Thank you, sir.
Thank you.
But I think dose of aceclofenac is a bit less according to Parcel. Okay, no issue. But I said you just dose is less. What you said. Sayali Rathod. Next, Gaurav Gupta. Kritika Upadhyay, be ready. Next four.
Next is Dr. Kritika Upadhyay. Is she there?
Yeah.
Come here.
A very good evening to all. I'll be showing a very interesting case of OSSN which presented like a vascularized corneal opacity. So this was the case, 71-year-old male presented to us with right eye gradual diminution of vision since 1 year and presented with this white mass over cornea and was referred to us for optical penetrating keratoplasty. So what it is vascularized corneal opacity or ocular surface squamous neoplasia. So look carefully. So arborizing pattern of vessels is suggestive of feeder vessels and it is arising from limbus. So it is more likely to be OSSN. We went ahead with AIOCMTC4. We could see feeder vessel and the opacity is above the corneal epithelium as we can see over here. So to confirm this, we sent the impression cytology and impression cytology was suggestive of presence of atypical cells and diagnosis of OSSN was confirmed. So we started as the patient was entity of corneal OSSN. So we started the patient medical management. So we started the patient on mitomycin C 4 times a day, 0.02%, 1 week on, 1 week off, 1 cycle. So after 1 cycle, we can see the mass has drastically reduced. After 2 cycles, only bit of opacity is there. And after 3 cycles, we can see it is completely gone. So here is the comparative pictures. We can see the mass is completely gone with the medical management, which confirms. So take home messages, OSS is not always limbal. We should be always careful. All vascularized opacity are not always benign. Careful clinical examination helps in suspecting, and in rare cases impression cytology may help in diagnosis, although OSSN is more of clinical diagnosis, and medical management is first in predominantly corneal OSSN. Thank you.
Any questions from the house?
So, sir, it is an unusual presentation. So this is the. Yes, sir.
So I have 2 questions for you. One is why you stop the medicine, like why you do in like 1 week and then 1 week off. Usually few people prefer, like I prefer 4 days and 2 days off and then again 4 days, 2 days off for a 1 month. Yeah. Second thing is, how is your experience with 5-fluorouracil?
There are a lot of regimes have been explained for mitomycin C, like Dr. Navar gives for continuous 3 weeks, or many other people give 2 week on, 2 week off. Some people give 3 days on, 3 week off. So there are various regimes have been explained. In our practice and our experience from where I have learned from PJ Chandigarh, so there we used to give 1 week on, 1 week off, 4 cycles maximum. So and that's working very well in our hands. Definitely, I don't have any experience of 5-fluorouracil, but reliferon we have been using in such case, interferon basically, and they also have a very excellent result in these cases, because if but I personally feel it has a slow onset of action. It requires to be given for longer duration. In this case, we gave mitomycin and it has a very good response. If the response has been slowed, we could have added with interferons also, and that could have saved the day.
So if in 1 month it doesn't resolve, do you go for the surgery or you repeat the cycle after some time?
Basically, we can switch the what medical management we are giving, because in surgery, in cases of corneal OSSN, is a bit tricky because we cannot remove it completely. We will remove it and we do alcohol epitheliectomy. Also, there are chances of residual, and we still need to give medical therapy post surgery also. And also, the chances of limbal stem cell deficiency in such cases is very high. So I personally feel if we can manage it medically, and in my experience, we have treated many corneal OSSNs, and they usually respond better than the limbal ones with medical management.
Right, dear. Thank you,
Kritika,
Dr.
come
Gaurav.
on. Thank you.
Dr. Kritika Upadhyay.
Good evening everyone. I am Dr. Kritika Upadhyay. I am going to present a case on granular corneal dystrophy type 1, a clinical case with unusual stromal opacities. So my patient is a 60 years old female, a resident of Jabalpur, homemaker by occupation. She came with the chief complaints of diminution of vision in right eye since 1 year. As per my patient, she was apparently alright 1 year back. Then she experienced diminution of vision in right eye, which was gradual in onset, progressive in nature, and was associated with glare in both the eyes. It was not associated with photophobia, pain, watering, colored halos, redness, or discharge. There is no history of any systemic illness or trauma. Patient went to a private practitioner for primary treatment, after which she came to NSCB Medical College and Hospital for further management. The past history: the patient have a history of cataract surgery of left eye done in the last year in October. The drug history is not significant. The personal history is within normal limits. Family history is not significant. The allergy history is also not significant. The general examination of the patient is within normal limits. The ocular examination of the patient is as follows. In the vision, in the right eye, the visual acuity, the best corrected visual acuity is 6/18 with a minus 0.5 diopter spherical, and in the left eye it is 6/9 with minus 0.5 diopter cylinder at 180-degree axis. The rest, the eyelids, the position of head, face and eyebrow are within normal limits. Coming to the eyeball, lacrimal apertures and conjunctiva, in both the eyes these findings were within normal limits. Coming to the cornea, in the right eye, the size and the shape were normal. Transparency, the arcus senilis was present in both the eyes, and multiple breadcrumbs like corneal deposits of different sizes were present in the central cornea with intervening clear spaces in between. The vascularization was absent and the corneal sensations were present. The sclera was normal in both the eyes. Rest of the examinations like anterior chamber, iris and pupil were within normal limits in both the eyes. The lens was cataractous in the right eye and pseudophakic in the left eye. The digital tension and tension by the Goldman applanation tonometer is normal in both the eyes. These are the clinical photographs of the right eye and the left eye showing the corneal deposits centrally with intervening clear spaces. This is the corneal diagram of the same. The fundus examination of both the eyes was within normal limits. The investigations done were also within normal limits. Few special investigations were done. The first one is the pachymetry. The central corneal thickness in both the eyes was within normal limits. The OCT, the anterior segment OCT of the HD cornea was done in both the eyes. Here you can see the corneal deposits which is involving the Bowman's layer and the anterior stroma in both the eyes. This is the raster of the same. The OCT macula is the thickness of the fovea is within normal limits in both the eyes with the posterior vitreous detachment as seen. The keratometry values and the axial length of both the eyes were as follows. My probable diagnosis in the right eye, it is granular corneal dystrophy type 1 with senile immature cataract, and in the left eye it is granular corneal dystrophy type 1 with pseudophakia. My differential diagnosis were lattice corneal dystrophy, macular corneal dystrophy, Schindler's corneal dystrophy, Rees-Buckler's corneal dystrophies, and Thies-Van-Ku's corneal dystrophy. Thank you. To conclude, we have to make a timely diagnosis and treat as per the staging to prevent the visual loss. Thank you.
पूछना है सर कुछ?
नहीं, मुझे तो नहीं पूछना है बच्चा से कुछ.
अच्छा.
Any house, any PG, any interested PG.
What did you do for this patient?
Actually, we just gave her lubricants. Abhi
नहीं, इसे corneal dystrophy
cataract
sir.
was done in the last year. Yeah. Yeah. We'll be operating her for the right eye cataract, and conservatively we have given her lubricants, and we have asked her to come for regular follow-up for the same.
Any help of contact lens in this case?
Yes, if there are currently there is no need as patient is not having symptoms, but if in recurrent corneal erosions we can give them bandage contact lens. Thank you.
Thank
Himanshu.
you. Himanshu Prakash.
Yogita Chaurashya. ये तो बहुत अच्छा केस है सर, हम लोगों ने भी एंट स्टक देखा हूँ, निकाला भी हूँ पकड़ के।
Should I start?
मैं तो एसी से लार्वा भी निकाला हूँ। ओके, स्टार्ट।
Okay. Good afternoon, everyone. So I'm presenting a case of an ant stuck in the eye. Animate foreign bodies in the eye constitute ocular emergencies with unique challenges like insect bites, missed body parts, and incomplete removal risk. Ant foreign bodies are particularly very rarely reported in the medical literature. A 71-year-old bedridden woman with restricted mobility due to spinal disc issue presented with sudden onset pain, watering, and foreign body sensation in the right eye. Symptoms were present for last 4 to 5 hours and woke her from her sleep. On slit lamp, an ant was found stuck at the inferotemporal conjunctiva. There was localized conjunctival congestion. Insect appeared dead with no movement, and cornea appeared slightly hazy. This is a magnified view of the insect showing all the body parts intact, but there's a slight dipping here at the mid body level. So we stained the cornea and stain was positive as the patient was vigorously rubbing the eye following the incident. There were certain treatment challenges. The ant was firmly embedded in the conjunctival tissue, making simple removal very difficult. There was risk of fragmentation. Forceful removal could leave body parts behind, causing complications. And the patient had pain and difficulty in sitting for long periods during examination and maneuvers. So that was also a challenge. I put some anesthesia drops and initially attempted to try to remove it with a blunt forceps, but the ant was too firmly embedded. So I made a small superficial nick with Westcott scissors adjacent to the ant and gently extracted the ant via blunt forceps, ensuring no parts remained. This is the post-procedure pic showing there's no retained body parts after successful removal. After that, I patched the eye with antibiotic and HPMC ointment, and conjunctival incision was left to heal naturally. Started on moxifloxacin and CMC eye drops, HPMC ointment at night, and also gave oral antihistamines to prevent itching. This is the second day picture of the conjunctival wound. It healed naturally without any complications. So after 7 days, we just followed up her for the 7 days period, and after 7 days, she was totally fine. Why ants in eyes are dangerous? Ant bites can cause severe inflammatory responses locally and systemically. Even anaphylaxis has been reported in literature. A retained insect, any insect can cause a foreign body granuloma, and the parts can penetrate intraocularly and cause further complications. A restricted ambulation in our patient could be an attributing factor for the event, as bedridden patients are particularly vulnerable to insect encounters due to limited mobility and inability to quickly respond to threats. We reviewed the literature and found 2 similar cases. Lim reported an ant bite on conjunctiva, removed it using band 30 gauge needle after multiple attempts. Prasad successfully removed conjunctival ant bite using blunt forceps without any complication. But for our current case, the ant was deeply embedded in the conjunctiva, so we used a slight incision with the forceps. Clinical decision making should be, we should assess the depth of insect, then we can try the blunt forceps for removal initially. If the patient is embedded deeply, we can use a very superficial conjunctival incision to aid the procedure. And post-op care is equally important. We should complication to avoid incomplete removal, excessive force which can cause damage and fragmentation, and delaying the treatment which can cause local tissue, deeper tissue involvement and further complications. Bedridden patient care should be emphasized upon. Their environment should be very safe and secure for them, and protective measures like mosquito net or everything else can be used for high risk patient with limited mobility. So the key learning points are, ant foreign bodies are rare but serious ocular emergency requiring immediate attention. Complete removal is critical as all the insect body parts must be removed, and surgically we can modify it by using a small conjunctival incision. These are my references. Thank you.
Very good. Sir, actually we learn how to prepare a paper from this. Otherwise, if this patient was in my OPD, it was a matter of 2 minutes only. Slit lip में ही मैं निकाल के रख देता. कहानी खत्म. Anyway, there are two speakers, Shayali Rathore and Himanshu Prakash. Is it they are here?
Question.
Yes, sir.
Yeah.
Yeah.
It's the toxins are.
All around. Yes, throat. That heals, sir.
I was in the dilemma of whether to suture the conjunctival wound or not,
not
but the
required.
patient was very, very uncooperative, so I thought just leave it like that.
Suturing is not required.
So,
Not
suturing
required,
is not
yeah.
at all required. Bare sclera is very important, and it yes. Sir, in 90s we do the pterygium surgery, just cutting and keeping it the same way. Anyway, this is the end of the session.
Why you have kept the picture of some foreign doctor? Why not yours?
Maybe I'm not that presentable enough.
Sir,
I don't
उसमें
know.
picture लगा, first presentation लगा.
Yeah. Can you start the presentation?
Plate.
इसको
दोबारा
प्ले
करना
करो,
इसको.
इसको दोबारा प्ले करो.
एक बार फिर से लगाना स्लाइड जरा.
No, first slide.
इस स्लाइड को प्ले करवाओ पहले फर्स्ट. Anyway, in the meantime, any of your young PGs and fellows, have you seen the caterpillar injury? बुआ पिल्लू हमारे बिहार में कहते हैं. Have you
This
seen
one,
this?
sir?
This one.
Yeah. So that's an AI generated picture. I just used it.
तुम अपना फोटो डाल देती ना. Next, अरे come on.
Okay.
From next time you put your photo. Why this?
Sure, sir. Thank you
Any-
for the compliment.
So if anyone have a caterpillar injury in eye, just you have to remove more than 30, 40, 50 hair on the slit limb with the forceps. And there only you can see that white hair in black. Otherwise you can't see that hair. Only the rubbing is rubbing. You are giving too many things. So if any person comes with a sir मुझे भुआ पिल्लू या कोई कीड़ा लग गया, must just see the palpebral conjunctiva. Huh? Sir, pardon?
You have removed everything.
Sir, I have seen a patient who came after 6 months. Ki, sir, I have a foreign body sensation. Again, I reported there is one follicle is moving out. It appears like bhala. Just get inside, and you will see black spot. You just catch it, and that long thread type. You will see that caterpillar here. Anyway, thank you all. I have a photo. Come on. सर नहीं सर आपके बिना वो फोटो गड़बड़ हो जाएगा.
नहीं नहीं आप लोग आगे जा रहे हैं नहीं अगर मैं यहाँ ठीक हूँ तो मैं सर आए ना सही
आ जाओ आगे आ जाओ.
नमस्कार सर.
बहुत मदद की है.
बड़ा आ गया.